and which can be a reason of development bronchial obstructive syndrome. So about guidelines, where you can find information about bronchial asthma. And the name of these guidelines, it's Global Initiative for Asthma, or GINA, and the last edition was established in 2019. And like the same with the guidelines about COPD, was established a new version in 2020. But the most important moment in the last version is about combination of bronchial asthma and COVID-19 viral infection. So bronchial asthma is a heterogeneous disease which characterized by chronic inflammation of the respiratory tract. Practically the same definition which we discussed in case of COPD, but there is difference. The presence of respiratory symptoms such as wheezing, shortness of breath, chest tightness, and cough, which vary in time and intensity and manifested together with variable airway obstruction. What they mean? The presence of respiratory symptoms like wheezing, shortness of breath, and chest tightness and cough, but some another cough if we consider with the inflammation group of disease. And the symptoms manifested usually together with different types and different variables and degree of bronchial obstruction or airway obstruction. Some definitions from guidelines. Bronchial hyperactivity, it's a diagnosis which significantly for childhood and which can continuously in adulthood in diagnosed bronchial asthma and COPD. It's the similar host factor for both bronchial obstructive disease. Bronchial hyperactivity is a functional disorder manifested by episodes of bronchial obstruction under the influence of stimulation that are safe for a healthy person. It's not a big problem, yes, but it's a base for development such disease like a bronchial asthma and like a chronic obstructive pulmonary disease. Phenotype of bronchial asthma. We discussed with you a group of phenotypes in COPD, and this definition also proceeds in bronchial asthma. Phenotype, a set of characteristics of the body, development as a result of interaction of genetic factors and the environment or environment pollution. Endotype is a subtype of the disease determined by the distinctive pathobiological mechanism. Exacerbation of bronchial asthma. Exacerbation, it's episodes of increasing shortness of breath or intensify shortness of breath, intensify cough, wheezing, or chest congestion, requiring changes in the usual regimen of therapy or usual dosage of therapy. Asthmatic status is an episode of acute respiratory failure due to exacerbation of bronchial asthma. So on the base of development asthmatic status, and the main sign of asthmatic status, it's developing bronchial obstructive syndrome, which leading to developing respiratory failure. And in the base, it's a place of bronchial asthma or mechanism of hypersensitivity of bronchial tree. About etiology, the scientists divide these two group factors, internal factors and external factors. About internal factors, first of all, it's genetic and the level of genetic predisposition to atopy or to hypersensitivity or to hyperactivity of the bronchial tree. Genetic predisposition to bronchial hyperactivity, sex, also by the medical research in childhood, bronchial asthma more often develops in boys, but in teenage and adult in women, and obesity. About external factors, more large group in etiology. And first place in group of external factors, it's allergens. House dust, first of all, house allergens, animals, cockroach allergens, fungal allergens, pollen plants and pollen plants allergens, and fungal allergens. Infection agents, mainly viral agents, take a role in etiology of bronchial asthma. Occupational factors, air pollutants like ozone, sulfur and nitrogen dioxide in the pollution, products combustion of diesel fuel oil, tobacco smoke, active or primary tobacco smoking and secondhand smoke, and diet. Diet included increased intake of high-grade foods processing, increased intake of omega-6 polyunsaturated fatty acid. For example, and we knew with you that omega-6 acid, it's a good acid from the fatty, but which some type of diet which saturated big amount of the omega-6 acid can lead into atopy, and this type of diet called Mediterranean was significant for country who had more seafood. And reduced antioxidants, the form of fruits and vegetables, and omega-3 polyunsaturated fatty acid as a part of fatty varieties of fish. Please pay your attention to this group allergens in group of from the diet allergens. I'm here. You hear me?
Yes,
Yes, ma'am.
Yes, doctor.
Okay.
Yes, doctor, we can hear you.
Continue. So causal agents, viral infection, medication, and causing exacerbation or triggers factors. Infection also, adverse weather condition, may be called condition outside, tobacco smoke, psycho-emotional stress, and physical activity can provoke exacerbation of bronchial asthma, can lead into development of asthmatic status like a critical.
Doctor?
Oh. Yes,
I'm
ma'am.
sorry, but the PowerPoint is, we can't see the
No PowerPoint. Okay.
Yeah. Thank you.
Continue. Corresponding, causal, and causing exacerbation, including physical activity, psycho-emotional stress, tobacco smoke, like primary and second one smoke, which can lead into asthmatic status, like a critical point of exacerbation of bronchial asthma and developing respiratory failure. About moment of pathogenesis of bronchial asthma. The morphological basis of bronchial hyperactivity in bronchial asthma is an allergic chronic inflammation of the wall of the respiratory tract. When we discussed with you chronic obstructive pulmonary disease, we discussed with you that it's also a chronic inflammation, but non-allergic. This different neutrophilic inflammation, which is significant for COPD, and allergic or eosinophilic inflammation, which is significant for bronchial asthma. And this inflammation characterized by the presence of mucus in the lumen of bronchi, which contains various cellular elements, dysplasia and desquamation of the epithelium of bronchial tree, also in this point leading to blockage of the lumen of the bronchi, an increase in the number of goblet cells, a thickening of the basal membrane, which leading to thickening of the wall of the bronchi and leading to decreasing the lumen of the bronchial tree, and infiltration of the whole membrane of the mucous membrane with lymphoid cells and granulocytes with a predominant of eosinophilic in the infiltrate and secretion. Eosinophilic type of inflammation. Look to this picture. There we can consider the normal bronchial tree. Normal bronchial tree, and the thickness of the wall of the bronchial tree and the thickness of the lumen of the bronchial tree to normally ventilation, to normally airflow. This asthmatic airway, asthmatic chamber fixed your attention on the smooth muscles which go around it on the bronchi, and this asthmatic airway, but not in the phase of exacerbation. Yes, increasing and enlarge the thickness of the wall due to eosinophilic type of inflammation, decreasing the lumen. It's already working like obstacle to airflow going to the lungs and leading to development elements of respiratory insufficiency, respiratory failure. And this the structure of the bronchial tree during asthmatic status or asthmatic attack or broncho-obstructive syndrome. The thickness and the structure inside the bronchi will be the same, but if you look to the tonus, of smooth muscles around of the bronchi, this tonus will be increased and it will be tightened, which leading to more obstruction of the bronchi. The main immunological markers of sensitization is increased the level of total fraction of immunoglobulin E in the patient blood serum and in the presence of specific immunoglobulin E antibodies to allergens. A substantial portion of immunoglobulin E fixed on mast cells and basophils. The mast cells is one of the leading place in the allergic reaction, and as a result of mast cells activation by the information complex of antigen and antibody, allergy mediators, histamines, cytokines, interleukins, leukotrienes are released, as well as the formation of new mediators and secondary stimulation of new push and new activities of mediators, prostaglandins, leukotrienes, and under the influence of these mediators, an immediately response develops acute bronchospasm. These mediators leading to formation hypertonus of smooth muscles around bronchi, swelling of the bronchial mucosa due to infiltration, and hypersecretion of bronchial mucosa. So the pushing of these mediators leading for three main points, which will be a cause of bronch obstruction. These mediators are also responsible for prolonged activation of eosinophiles, neutrophils, platelets, for the formation of inflammation in the tissue and in the development of a delayed reaction. A decrease in the level of calcium in the intercellular medium leads to a suppression of synthesis leukotrienes. And in patients with bronchial asthma, eosinophils are often found in large quantities in the fluid of bronchial alveolar lavage. Also, a big amount we can find in the general blood analysis, which confirm for us eosinophilic type of inflammation. With an exacerbation of the disease, signs are detected activation of eosinophilic and the increased secretion of mediators, main protein, eosinophilic cationic protein, eosinophilic neurotoxin, cytokines, chemokines. And in bronchial asthma, a secondary deficiency of antioxidants enzymes is detected, which can lead to an increase of the level of free radicals that can induce the secretion of chemokines also. In this turn can lead to an increase in the infiltrative component of inflammation. Infiltrative component leading to increasing thickness of the wall of bronchi. An imbalance in the functional state of the sympathetic and parasympathetic part of the nervous system also plays a role in the pathogenesis of bronchial asthma. For many patients, the predominance of the sympathetic part of the autonomic nervous system, a perverse reaction to adrenaline are significant, and antibodies against the functional state of effector cells of the bronchi and lung adrenergic receptors. So this balance in sympathetic and parasympathetic part of the nervous system also take a role in genesis of bronchial asthma and play a role in exacerbation. If you look to the scheme of pathogenesis of bronchial asthma, we started with you from the point of releasing of primary mediators like prostaglandins, thromboxane, platelet aggregation factors, leukotrienes. This first pool of mediators stimulated and leading to eosinophils, neutrophils, thrombocytes, chemotaxis to the inflammatory focus and transportation the cells to the inflammatory focus. In this turn, this act leading to development and stimulation second pool of the same mediators. Second pool leading to contractility and proliferation of smooth muscles. At the same time, thrombocytes and neutrophils. At the same time, increased that. The same time, increased vessels permeability and development the place edema or infiltration in this point, and a secondary pool of mediators leading to development vasospasm. All these points leading to big two moment. Thrombocytes and neutrophils aggregation and vasospasm, leading to microdescularity impingement, and also we can't exclude the descular component from the eosinophilic inflammation, and all other points leading to bronchial constriction due to hypersensitivity or due to increasing squamous and desquamotic epithelium and secretion and hypersecretion in the lumen of the bronchi and hyperresponsiveness from the side of the bronchi to allergic history. Also, second pool of mediators can lead into hyperalgia and thin development inflammation, mucociliary transport impingement, and leading to mucus hypersecretion and leading to bronch obstructive syndrome. And if we look to the final stage of the slide, look, bronch obstructive syndrome, microdescular component, and bronchial constriction, and hyper responsiveness from the side of the bronchus. About epidemiology, at least 300 million patients worldwide suffer from bronchial asthma. According to a recent epidemiological study by World Health Organization, the prevalence of bronchial asthma among adults till the 70%, and among children and adolescents about 10%. In the emergency room and in the primary department of hospitals in developed countries, patients with asthma exacerbation accounted for up to 12% of all visits. It's a large group of patients, and 20 and 30% from previous group need hospitalization in specialized department, pulmonary department, and about 0.7% of patients in the intensive care unit and needed oxygen support. About classification of bronchial asthma. By internal classification of disease, the 10 version. Also, it will be group G, 45.0 bronchial asthma with a predominance of an allergic component. J, 45.1 non-allergic bronchial asthma. J, 45.8 mixed bronchial asthma, allergic and non-allergic component. And the J, 45.9 unspecified bronchial asthma. Which moment we can differentiate it in classification. First of all, it's severity classification, and there is there are two subgroups. First, identified bronchial asthma or firstly diagnosed bronchial asthma, and bronchial asthma in patients which already received treatment. Next moment, classification by level of control of symptoms, classification of bronchial asthma exacerbation by severity, and phenotype classification of bronchial asthma. In patients with firstly diagnosed bronchial asthma, severity classification is based on the clinical picture only. It's sufficient to have one of the listed criteria for the severity of the corresponding group in order to attribute the patient to a more severe degree of severity. And look at these two slides. Classification of firstly diagnosed bronchial asthma based on the symptoms. So we need to assess daytime symptoms, nighttime symptoms or nighttime attack, exacerbations, and functional indicators. About daytime symptoms, intermittent bronchial, we can differentiate it with you next stages or next degree of first diagnosed bronchial asthma, intermittent bronchial asthma and persistent bronchial asthma, which separated to 3 stages, mild, moderate, and severe. About daytime symptoms, intermittent bronchial asthma less than 1 time per week, nighttime symptoms in case of intermittent not more than 2 times a month, nighttime attack. Exacerbations are short, and functional indicators for forced expiration volume for first second should be more than 80% from the normal average. Persistent bronchial asthma, daytime symptoms in case of mild, more than 1 time per week but less than 1 time per day. Moderate, daily symptoms and daily use of inhalators forms of glucocorticosteroids. Severe, daily symptoms, limitation of physical activity. Nighttime symptoms, mild, not more than 2 times a month. Moderate, nighttime symptoms more than 1 time per week, and severe, frequent nighttime symptoms. Exacerbation. In case of mild persistent bronchial asthma, exacerbations may decrease physical activity and disturb sleep. Moderate exacerbations can lead to limited physical activity and sleep disturbance, and severe frequent exacerbation. Functional indicators. In case of mild bronchial asthma, forced expiration volume more than 80% from the normal average. Moderate, between 60 and 80% from the average, and severe, less than 60% from the normal average for this person. Next, classification of bronchial asthma by severity in patients which already received the treatment. Some another key in classify this person. The severity of bronchial asthma in patients receiving treatment is evaluated retrospectively, which based on the amount of therapy required to control symptoms and exacerbation. Enough or not enough this dosage of therapy. Since the course of bronchial asthma is extremely variable and the severity of the disease can vary over months and years. Classification of bronchial asthma by level of control. Control level: well controlled, partially controlled, and uncontrollable bronchial asthma. What we need to assess are the past 4 weeks the patient had. Look, daytime symptoms more than 2 times a week, yes or no? Bronchial asthma night awakening or nighttime symptoms. The need for a drug to relieve symptoms more often than once a day, and any activity restriction due to asthmatic status. Look, we assess yes, no, yes, no, yes, no, yes, no. Yes, and you can assess like one bar, or you can interpret it one symptom. Well controlled, none of the list of this symptom. Personally control 1 or 2 from the list of previous symptoms. For example, bronchial asthma night awakening and some additional pushing of drugs for control exacerbation. And uncontrollable bronchial asthma, 3 or 4 from the list. So practically all symptoms were present in our patient. Patients with any degree of severity of bronchial asthma can have mild, moderate, or severe exacerbation, and the severity of exacerbation of asthma is established by clinical criteria. In order to assign the patient to a more severe category, at least one of the relevant criteria is sufficient. Which criteria? By the severity: mild, severe, and life-threatening asthma or asthmatic status. Mild exacerbation of asthma or moderate exacerbation of asthma severity. Criteria of this degree: symptom worsening, peak expiratory flow between the 50 and 75% of the best of calculated result increased, frequency of use of ambulance drugs care in practically 1/2 of cases of the additional use in nebulizer shape, and night awakenings due to symptoms of asthma and requiring the use of drugs ambulance. Severe exacerbation of asthma. Peak expiratory flow in average between 33 and 50% of the best values. Respiratory rate 25 per minute, it's already respiratory failure. Pulse 120 per minute, and inability to utter a phrase on one exhale. Life-threatening asthma or asthmatic status. Peak expiratory force or flow less than 33% from the best values. Saturation of oxygen in the arterial blood less than 92, partial pressure on oxygen less than 60 millimeters, but about pressure of the carbon dioxide is between 35 and 45 millimeters, silent lung during auscultation, development cyanosis due to respiratory failure, development coma due to losing the consciousness in case of respiratory failure, weak breathing efforts, development bradycardia in case of the compensation, hypotension, clinic of fatigue, and clinic of stun or coma, or losing the consciousness or regret the consciousness. And next severity is close to fatal asthma, development hypercapnia, where pressure of carbon dioxide is more than 45 millimeters, and or the need of mechanical ventilation lungs. So emergency, and the patient needed mechanical ventilation of the lungs. About asthmatic status means an episode of acute respiratory failure due to an exacerbation of asthma, And in modern classification, the last version of classification, asthmatic status it's equivalent to the concept of life-threatening asthma and close to fatal asthma. In the modern classification, we don't need to separate asthmatic status. It's the same, close to fatal asthma and life-threatening asthma. The last type of classification of bronchial asthma is classification by phenotypes. First of all, allergic bronchial asthma. The most easily recognized phenotype in which bronchial asthma usually begins in childhood is associated with the presence of other allergic diseases like atopic dermatitis, allergic rhinitis, food allergies like a background in the patient or relatives. Eosinophilic airway inflammation is significant to this phenotype of bronchial asthma, and patients with allergic bronchial asthma usually respond well to therapy inhalation form of glucocorticosteroids. Surely it's around 80% of all patients with bronchial asthma, and the allergic phenotype significant for bronchial asthma. But there are another one, non-allergic bronchial asthma. Occurs in adults, is not associated with a background of allergies and atopies. The profile of airway inflammation in patients with this phenotype can be eosinophilic, neutrophilic, and mixed or small granulocytic, depending on the nature of the inflammation, and patients with non-allergic asthma may not respond to inhalated forms of glucocorticosteroid therapy. Bronchial asthma with a late debut. In some patients, especially women, asthma develops for the first time in adulthood. These patients are often allergic and, as a rule, are relatively refractory to steroid therapy, or high dosage of inhalation from glucocorticosteroids are required. Bronchial asthma with fixed airway obstruction. In some patients with a long history of bronchial asthma, apparently due to bronchial remodelium, the wall develops fixed airway obstruction or non-reducing obstruction. And bronchial asthma in obese patient, patient with obesity. Obesity in bronchial asthma patients often have pronounced respiratory symptoms not associated with eosinophilic inflammation, but also it's some atopy. About diagnosis of bronchial asthma and our list. First of all, we should establish when we have to establish etiology if it's possible. We have to establish severity of bronchial asthma. We have to establish level of control of exacerbation. We have to assess concomitant disease which may affect to the course or to the exacerbation of bronchial asthma, and if present, an exacerbation indicating its severity. In this slide, you can assess examples of diagnosis. For example, allergic bronchial asthma of moderate severity control course, year-round allergic rhinitis, mild cures, sensitization to house dust, mild allergens. Or another type, non-allergic bronchial asthma of moderate severity, partly controlled course, recurrent polypose sinusitis, intolerance to non-steroidal anti-inflammatory drugs or aspirin triad. And allergic bronchial asthma of moderate severity, exacerbation of moderate severity, seasonal allergic rhinitis, severe course, and sensitization to pollen allergens. About clinical picture, patient with bronchial asthma. Some characteristic symptoms for bronchial asthma are wheezing, chest tightness, and coughing. Symptoms are variable in time and intensity and often worsen at night or early in the morning. Why worsen condition of the patient, and why we discuss disease of bronchial asthma nighttime symptoms or nighttime headache? or early morning, because early morning it's a time of activation sympathetic part of nervous system, which working there like a provoke, like a stimulation of constriction of the smooth muscle. Clinical manifestation bronchial asthma can provoke respiratory viral infection, can provoke by exercises, exposure to allergens, weather changes, contact with non-specific irritants. About typical clinical symptoms in children, the same: wheezing, coughing, shortness of breath, often breathing at night or on waking. With the development of asthma exacerbation in children, an abasis, dry or unproductive cough appears, and sometimes before vomiting, and expiratory dyspnea and nausea wheezing. Vomiting for children, it's non-specific community reaction, and it can assign many types of disease. The diagnosis of bronchial asthma is recommended to be established on the basis, first of all, complaints and anamnesis of the patient, the results of functional examination methods, specific allergological examination, and exclusion of other diseases to exclude another reason of bronchial obstructive syndrome. When collecting anamnesis from the side of the patient, you have to discuss the entire set of symptoms for the last 3 or 4 months, paying particular attention to those who bothered during the 2 previous weeks. When making a diagnosis, the response to therapy should also be considered, and disease control. Before considering the diagnosis of severe asthma, it's necessary to exclude the most common problems. For example, poor inhalation technique. Till the 80% of patients don't know about normal technique of inhalation. Low adherence to treatment, up to 50% of patients. Erroneous diagnosis of bronchial asthma, the presence of concomitant disease which affecting to the course of bronchial asthma, and continued contact with the trigger, or allergen and confirmed sensitization, or some professional triggers. In guidelines about bronchial asthma, establish 2 groups of syndromes, or 2 groups of compliance, or 2 groups of clinical signs. Clinical signs that increase probability of bronchial asthma, and clinical signs that reduce probability of bronchial asthma. So first group, increased probability of bronchial asthma. The presence of more than one of the following symptoms: wheezing, feeling of stuffiness in the chest and cough, especially in case worsening symptoms at night and early in the morning, the occurrence of symptoms during exercise, exposure to allergens and cold air, and the occurrence of symptoms after taking aspirin or beta blockers. Clinical signs that reduce probability of bronchial asthma: severe dizziness, darkening in the eyes, paresthesia, chronic productive cough in the absence of wheezing, constantly normal chest examination results in the presence of symptoms or during the bronchial attack, voice change, the onset of symptoms solely in the background of colds, the presence of a long smoking history, more than 2 packs a year, and we need to assess the index of smokers, heart disease, and normal peak expiratory flow or spirometry in the presence of clinical manifestation. Normally averaging levels of forced expiration volume for 1 second and peak expiratory force for 1 second practically exclude the diagnosis of bronchial asthma. Next, Clinical signs that increased probability of bronchial asthma: the presence of atopic disease in medical history, the presence of bronchial asthma and/or atopic disease in relatives, common dry wheezing and listening to auscultation of the chest, low level of peak expiratory flow and forced expiratory volume, and peripheral blood eosinophili unexplained by other causes, by Gelmins, for example. And group 2 reduce probability of bronchial asthma. To assess asthma control, it's recommended that to use the special scale asthma control questionnaire and the asthma counter tests, like a test for check level of the control on the base therapy. At this slide, you can find the algorithm of diagnosis patient with bronchial asthma. For example, where we should start. Patient with respiratory symptoms. Any type of symptoms are its symptoms typical of asthma. Which symptom typical for asthma? Wheezing, cough, and chest tightness. Not shortness of breath, chest tightness. Our next mind, so typical. Next, we have to detail in history and examination in key of asthma, and history and examination supports asthma diagnosis. Yes or no? For example, yes, and we lead into blue way. Perform spirometry or peak expiratory flow with a revisibility test or with using bronchodilatators. Results support asthma diagnosis, yes, treat for asthma. So, symptoms typically for asthma: anamnesis, compliance, examination, which consent confirmed diagnosis bronchial asthma. Next, step, instrumental diagnosis, spirometry or peak flowmetry to assess forced expiratory volume or peak expiratory flow, confirming diagnosis, treatment from asthma. Another respiratory symptom, for example, productive cough, maybe chills and fever, not typically for asthma. No, and we lead into yellow way. Further history and test for alternative diagnosis. Alternative diagnosis confirm, continue, yes? So next, repeat to another caution or either each other tests. Confirm asthma diagnosis? No. Next, consider that of treatment for most likely diagnosis or refer for further investigation. If the patient not confirming the special clinical symptoms, no special dates due to examination, no any information from the such allergic background in childhood and adulthood, and not confirming bronchoobstructive syndrome due to spirometry, we excluded bronchial asthma and we need to find alternative diagnosis. Any of the listed symptoms in the column clinical signs that reduce the likelihood or the probability of bronchial asthma indicates an alternative diagnosis and the need for further examination of the patient. Differential or alternative diagnosis depending on the clinical situation or clinical case, and you can use bronchoscopy, computer tomography of the chest organs, as well as a refer for specialist advice, gastroenterologist, dermatologist to confirm or to improve your diagnosis. Which changes are significant for patient during our examination or status presence patient with bronchial asthma? Patient condition can be different and depends from the level of respiratory failure, can be severe, can be moderate, can be satisfactory. Patient's position in bed. In bed during an attack of bronchial asthma, you can find the patient in forced position with a fixed shoulder girder, which leading to concluding additional respiratory muscle to respiratory process. The patient usually sits in bed with his head resting on his knee on the back of the chair, and the patient breathes loudly, often with a whistling noise. His mouth is open, and it's also a sign of respiratory failure, and his nostrils are swollen. Due to face examination, you can find swelling of the cervical dense appears, which decrease with inhalation. The patient's face is puffy and diffuse cyanosis or central cyanosis, like a sign of respiratory failure. Examination of the skin. With an expanded clinic of an attic of suffocation, it's most and in some patients sweat trickles down from the face, neck, and chest. Chest examination, more informative for us. The chest of the emphysematosus form, like in the high point of inhale during an attack, expands and occupies an inspiratory position in the position of maximum inspiration. The auxiliary muscles of the shoulder girdle, back, and abdominal wall are actively involved in the process of breathing. Muscles are tense and their efforts increase during expiration. The external and internal intercostal muscles actively participating in the act of the breathing and lead to the fact that the ribs are horizontally located, and more horizontally localization of the ribs significantly for emphysematosus type, and the intercostal space are smoothed. Breathing is often rare, 10 or till 14 respiratory movements per minute, and in some patients on other contrary frequent. During palpation of the chest, you can find a rigid chest is determined during assess rigidity of the chest, weakening of forced trembling or attenuation of forced trembling due to emphysematosis changes in all departments due to increased airiness of the lung tissue due to increased elasticity force of the alveoli. Lung percussion. In case of comparative lung percussion, the appearance of the box sound over the entire surface of the lungs is noted, and boxes sound significant only for one condition, for emphysema. Topographic percussion of the lungs. We can find with you displacement of the boundaries up and down, an increase in the width of the cranial fins or cranial area, limitation of the mobility of the low pulmonary margin or low boundary of the lungs. With an attic of bronchial asthma, at the date of examination, palpation, percussion of the chest correspond to the syndrome of increased airiness of the lung tissue. All signs of emphysema. During auscultation of the lungs against the background of attenuation of vesicular breathing, listen to a large number of dry breathing, often heard from a distance, and with a pronounced obstruction of the small bronchi and accumulation of viscous sputum in them, wheezing cases to be had, and so-called mute lung or silent lung, which indicates the second stage of asthmatic status, when you can't find any respiratory sound. And bronchophonia is attenuated also over the entire surface of the lungs. Laboratory diagnostics of bronchial asthma. General breath analysis. A patient with bronchial asthma in the peripheral blood is characterized by the appearance of eosinophilia and moderate lymphocytosis. Depends from the reasons of exacerbation. When examining sputum, it's a vitreous mucus or mucus like a glass, viscous. With microscopic examination, many eosinophilic are found in the view, and often Cushman spirals and charcoal-laden crystals. It's significant for analysis of the sputum in case of bronchial asthma. Spirometry No in other special laboratory diagnostics, only general blood analysis and analysis of the sputum to contain it. Instrumental diagnostics, the main. Spirometry. In all patients with suspected diagnosis of bronchial asthma, recommended to use spirometry is the initial study to identify and assess the severity of airway obstruction. Repeated lung function tests are often more informative than a single examination. And look, normal spirometry or peak flowmetry don't exclude the diagnosis of bronchial asthma. All patients with asthma recommended to perform a bronchodilation test to determine the degree of reducible or reducing of obstruction under the influence of bronchodilator's drugs. The bronchodilation test is considered positive if after inhalation of the bronchodilator's usually shorter action, the bronchodilation rate by volume of forced expiration for 1 second is at least 20% and the absolutely increase in 20 milliliters or more. In absolutely counting, increasing more than 200 milliliters by spirometry. In patients with normal spirometry, to confirm the diagnosis of bronchial asthma, it's recommended to repeat the examination during the period of symptom or during the period of exacerbation, or the condition of the patient allows after the withdrawal of bronchodilators. Bronchial hyperactivity. In patients with normal spirometry and with a negative bronchial dilatator tests, it's recommended to use tests for the detection of bronchial hyperactivity and using bronchoconstrictor tests to confirm the diagnosis of bronchial asthma. And in fact, we need to confirm the ability of the bronchus to ability to constriction of the bronch to the answer for bronchoconstrictors. The detection of bronchial hyperactivity is based on measuring the response of the forced expiration volume for 1 second indexed to the inhalation of the increasing concentration of methylhalane, and the answer is calculated as concentration or dosage of the provocative agent, causing a 20% drop in the rate of forced expiration volume for 1 second. Some word about asthma of physical activity. Patients with suspected so-called asthma of physical activity, especially in children and young patients, bronchoconstrictors is recommended test for physical activity to exclude bronchospasm caused by cooling and drying of the respiratory tract mucosa during exercises. A positive response to the load, to physical control load, forced expiratory volume drop more than 10% is a specific indicator of bronchial asthma. And this test is more specific but less sensitive than studies with methylhalane for the diagnosis of bronchial asthma. In patients with clinical symptoms of bronchial asthma who are unable to perform spirometry or additional diagnostic tests, recommended to use multiply measurements of peak expiratory flow rate or peak expiratory flow, which performed for at least 2 weeks to confirm airflow variability. In patients with typical respiratory symptoms, detection of increased mean daily variability of peak expiratory flow, more than 10% in adults and more than 30% in children, confirms the diagnosis of bronchial asthma. Also, some words about fraction of nitric oxide in inhalated air, or index of FeNO, FeNO. It's a marker of allergic inflammation. In case of asthma, it's recommended to study the fraction of nitric oxide in inhaled air. And this signs is elevated in eosinophilic bronchial asthma or allergic bronchial asthma in 80% of all populations on patients with asthma, and is associated with a good short-term response to glucocorticosteroids. The level of fraction of nitric oxidase is also increased with eosinophilic bronchitis, ATP, and allergic rhinitis, and decrease in smokers, decrease during bronchospasm, during exacerbation, and the early phase of an allergic reaction. The normal values of a fraction of nitric oxides, especially at the moment when the symptoms are absent, don't exclude the diagnosis of bronchial asthma, but it's something new in diagnostic of bronchial asthma. Bronchial asthma exacerbation. Bronchial asthma exacerbations are episodes of increasing shortness of breath or worsening symptoms, cough, wheezing, or chest congestion requiring changes in the usual treatment regimen. An exacerbation of bronchial asthma is characterized by a decrease in the post-expiratory volume and peak expiratory flow. Exacerbation can develop in patients with a known diagnosis of bronchial asthma and may be the first manifestation of first clinical symptom of bronchial asthma. Bronchial asthma exacerbation can develop in any patient regardless of the severity of the disease, but more often occurs with difficult to control bronchial asthma or not poor control. The rate of development of an exacerbation of bronchial asthma can vary significantly in different patients, from several minutes or hours to 10 and 14 days, as well as the resolution time of an exacerbation from 5 to 40 days. Patients with high risk of asthma Patients with a high risk of asthma-related death are recommended to be trained in seeking medical help for any worsening during the course of the disease. There is a special group for patients with bronchial asthma. This group includes patients with the presence of such risk factors, like as history of life-threatening exacerbation or closer to fatal bronchial asthma, history of episodes of mechanical ventilation or mechanical ventilation exacerbation due to asthma, history of development pneumothorax or pneumomediastinum due to exacerbation, hospitalization due to exacerbation of asthma over the past year, psychological problem, socio-economical factors, low income, inaccessibility of medicines, recent dose, reducing or complete cessation of glucocorticosteroids, low complaints to therapy, and decreased perception of shortness of breath. Which reasons are for exacerbation of asthma? Various triggers can induce an airway inflammation or provoking acute bronchospasm can lead to an exacerbation of bronchial asthma. These triggers can vary significantly in different patients. The main triggers surely include respiratory tract infection, and we discussed it with you. Mainly viruses, more often it's a group of rhinoviruses, allergens, airborne pollutants, physical activity, meteorological factors, the use of certain medication, for example, beta blockers, and it's clear why, yes, because it's stimulation of B receptors, which are located also in the bronchial tree. In patients with aspirin bronchial asthma associated non-steroidal anti-inflammatory drugs, emotional reaction, and so on and so on. Other factors that can lead to an exacerbation of bronchial asthma are exacerbation of rhinosinusitis, gastroesophageal reflux disease also, pregnancy can be this factor, and inadequate therapy or not good control therapy. Risk factors for exacerbation include symptoms of uncontrolled bronchial asthma, inhaled glucocorticosteroids not assigned, poor adherence to therapy, excessive use of short-acting B2 agonists, low forced expiration volume, especially less than 60%, significantly physiological or socioeconomical problems, external influence like a smoking, exposure to allergens, like a concomitant disease, rhinosinusitis, gastroesophageal reflux disease, confirmed food allergies and confirmed obesity, eosinophilic sputum and blood, pregnancy, and the presence of one of or more severe exacerbation in the last year. Clinical picture of exacerbation of bronchial asthma. When examining a patient with exacerbation of bronchial asthma, recommended to study the history of disease, determine its severity and potential provoking factors, evaluate the presence of complication and the response to therapy. A clinical evaluation of the patient with exacerbation of bronchial asthma, increasing shortness of breath and worsening gas exchange, should be carried out very quickly while maintaining sufficient footness and maybe on the background of the oxygen supporting. In the treatment of exacerbation in all patients with bronchial asthma, it's recommended to regularly evaluate the criteria for the severity of exacerbation, and we have to return into classification of exacerbation of bronchial asthma, in particular respiratory rate, heart rate, peak expiratory flow, and pulse oximetry to assess saturation of oxygen. Clinical signs of severe exacerbation. First of all, respiratory distress syndrome, including lack of air to complete the offer in one breath, development tachypnea, lack of breathing sounds or dumb lung or mute lung or silent lung, cyanosis or decreased consciousness. Patient with a decrease in blood oxygen saturation less than 92% and or other signs of life-threatening or close to fatal bronchial asthma recommended to study arterial blood gases. Signs of life-threatening asthma, in addition to low levels of saturation oxygen, include changes in the sphere of consciousness, confusion, drowsiness, staining, coma, different levels of regret, fatigue, cyanosis, weak respiratory effect, bradycardia, hypotension, lack of respiratory noise, decreased peak expiratory force less than 33%. A chest X-ray in a direct projection is recommended administered to patients with bronchial asthma exacerbation. And in fact, it can be used for patients with bronchial asthma to exclude mediastinal emphysema or pneumothorax-like exacerbation, with like a complication, with suspected pneumonia in case of continuously fever, chills, and other signs. Clinical signs of menacing exacerbation of life and the need for mechanical ventilation. So we finished with you for today about bronchial asthma.